Good evening, friends. Good evening, good night, good morning, and good afternoon. The people, all my friends who joined from different parts of the world. We have a small audience right now, but we are almost of the others are expected to join us soon. Anyway, welcome you all back to our program Weekend with a Maestro, episode 7. Unfortunately, we are holding this event middle of the week at late in the evening because this program had to be postponed because of some technical issues. This was supposed to be on 13th February 2022 Sunday, but had to be postponed because of the technical glitches, which we cannot avoid many a times. Unfortunately, anyway, welcome back. After that, also subsequent to 2 weeks, we couldn't organize this program because of my traveling schedule. Many friends wrote to me why we do not have program this weekend. Thank you very much for your interest. It's your interest which motivates us. Anyway, welcome back. Now we are having this program. So before starting some meeting etiquettes, I would like to tell you, please mute your audio and avoid the external disturbances. If you have a query, please raise your hand. You raise your hand whenever you have a doubt, whenever you want to ask something, whenever you want to clarify. You can ask, you can clear your doubts anytime you want. You can stop me or stop the faculty who is there today, who is a very kind man, a good friend, and he will be very happy to stop and answer all your questions. I'm sure about it. Okay. And also, anyway, if you have some queries directly to me or the faculty, you can use the chat box for asking questions. And of course, at the end of the day, at the end of the presentation, we are going to have a final discussion where we can clarify all the doubts. Okay. And this program is sponsored by my medical college, Basveshwara Medical College and Hospital, Chitradurga, and Karnataka ENT Hospital and Research Center, Chitradurga, and Champions Educational Medical Society, Chitradurga. And we have no conflict of interest. We are not gaining anything financially out of this program. Okay. And with this, friends, the next weekend with a maestro, that actually episode 8 will be on day of tomorrow, that is 4th March 2022. This is also a postponed program from 25th February. And this program will be on cochlear implantation by facial recess method. Okay, look forward to have you also on Friday with us. Friends, today let me welcome our maestro of the evening, a friend whom I have never met physically. Unfortunately, I have never met him face to face, but we are there on most of the social media. We are friends to each other. We have spoken on telephone each other. I am a deep administrator of this great friend, none other than Dr. Sanjeev Kumar, who happens to be a senior consultant and managing director of Janki ENT Hospital Maternity Center at Patna, and he's director of the hospital also. And I'm telling you one thing great about him is he happens to be one of the pioneer of endoscopic otology in India, and he organized the first ever global endoscopic otological surgeries in India at Patna. That is, I really very appreciative of him. Dr. Sanjeev ji, welcome.
Thank you, sir. Thank you very much.
Yeah, great to hear Dr. Sanjeev ji. I can read a lot, from your CV, but that won't be nice. I would like to hear from your voice, like your journey, where you started your medical career, where you started your MBBS career, and how you reach where you are today. I want to hear from your mouth, please.
Actually,
Yeah.
I want to correct yourself because I met in 2006 or 7 in Patna.
Okay. Yeah. I remember that meeting. Yes.
Probably we were not so much
known to each other. Yes.
known to each other.
Yeah.
That's why you forget. And
Yes.
for me and my journey, and I did my MBBS from Nalanda Medical College, Patna, and then I tried for PG preparation, and I got admitted in PMCH. And from PMCH, I went every places.
Okay.
Where we used to, particularly in Bhimhans, under the guidance of Avintabh Rai Chaudhary, we learned a lot of things there.
Okay.
And then in somewhere in Maulana Azad for few workshop, and even in major city of this country, I went there. And probably I learned most of the surgical technique by YouTube's and cadaver dissection, what I learned in earlier days. So
Okay.
if I had to say something about this about journey of the mine up to here,
Yeah.
I can play one video if you allow me, and because
Yes, 1 minute.
always there is always a role of great teachers in
Yeah.
anybody life.
Yeah.
But if you have interest in learning, you can
Yeah.
learn in different way, whether you have a great teacher or not.
Yeah.
So
Yeah.
would you allow me to just play
Yes, yes.
one
So
video?
definitely we'll go to that. Before that, okay, let the show begin. I am going to stop my my presentation. You can share your presentation now. Yeah.
Okay.
Yeah. Now we have in front of you. Okay.
Yes. So this is my presentation,
Yes. Slideshow.
and the this is video. Please listen it, and please pardon me if it is inconvenient to anybody. And this is disclaimer.
Not at all. Not at all. Shouldn't be. You can play it.
And this is in Hindi, so please listen it.
You
Okay.
will have to translate because we have an international audience. We have friends joining from Indonesia as well as Africa.
लेकिन गुरु द्रोण ने यह कहते हुए शिक्षा देने से मना कर दिया कि वह इस समय राजपुत्रों के अलावा किसी और को शिक्षा नहीं दे सकते। गुरु द्रोण की बात सुनकर एकलव्य और उसके पिता निराश हो वहां से लौट आए, परंतु एकलव्य द्रोणाचार्य को अपना गुरु मान चुका था और वह यह भी जानता था कि धनुर्विद्या उसे उनसे बेहतर कोई और नहीं सिखा सकता। फिर उसने द्रोणाचार्य के आश्रम से सटे हुए वन में गुरु द्रोणाचार्य की प्रतिमा का निर्माण किया और उसी प्रतिमा को गुरु द्रोण मानकर नित्य धनुर्विद्या का अभ्यास करने लगा। इसी तरह जब कई महीने बीत गए और जब एक दिन गुरु द्रोण कौरवों और पांडवों को धनुर्विद्या सिखा रहे थे, उस समय एक कुत्ते की भौंकने की आवाज आई, जिसकी वजह से सभी का ध्यान भंग हो गया। परंतु कुछ समय बाद कुत्ते की भौंकने की आवाज बंद हो गई, जिससे गुरु द्रोण सहित सभी कौरव और पांडव हैरान हो गए। फिर वे उसी ओर दौड़े जिधर से कुत्ते के भौंकने की आवाज आ रही थी। वहां पहुंचकर उन सभी ने देखा कि किसी ने कुत्ते के मुंह को बाणों से भर दिया है, लेकिन रक्त की एक बूंद भी नहीं गिरी। यह देखकर सभी एक दूसरे को देखने लगे। फिर द्रोणाचार्य ने जोर से कहा कि ये किसने किया है। तब एकलव्य उनके पास आया और प्रणाम करते हुए बोला, गुरुदेव, आपकी कृपा से मैंने ही इस कुत्ते का यह हाल किया है। एकलव्य के मुख से ऐसी बातें सुनकर गुरु द्रोण ने उससे पूछा, बालक, तुम कौन हो और मैं तुम्हारा गुरु कैसे हुआ? तब वह बोला, गुरुदेव, मैं वही एकलव्य हूँ जो अपने पिता निषाद राज हिरण्यधनु के साथ आपसे शिक्षा ग्रहण करने आया था, परंतु आपने मना कर दिया था। लेकिन मैंने हार नहीं मानी और आपकी प्रतिमा के सामने रोज धनुर्विद्या का अभ्यास करने लगा और उसका परिणाम आपके सामने है। एकलव्य की बातें सुनकर गुरु द्रोण का गला भर आया और अपने मन में कहने लगे कि उन्होंने एकलव्य को शिष्य नहीं बनाकर बहुत बड़ी गलती की। फिर वो एकलव्य को अपने सीने से लगाने के लिए आगे बढ़े और कुछ वक्त चलने के बाद उन्हें अर्जुन को दिए हुए अपने वचन का स्मरण हुआ।
So
Yeah, that's a great story of Ekalavya. For friends who do not know this story from history, Ekalavya is a student who wanted to learn archery from this great teacher, Dronacharya. But Dronacharya, he has given his word to some of his, dearest pupils that he will not teach anybody other than them. But, just by observation, Ekalavya learns complete archery. Okay. And the teacher Dronacharya as well as his pupils are surprised by his feat, just by observing from a distance, he has learned, he has mastered archery. That's what Dr. Sanjeev he wants to convey today. That
I want
is, even though he didn't have an opportunity to directly work under a maestro, a master, with mere observation, he has learned so much. That's a great story, Dr. Sanjeev. Very, very motivational story, motivating story. Thank you very much for that story. Yeah.
There is two messages in this video. One,
Yeah.
you must have a respect of your teacher,
Yes.
and next, you must have a urge to learn. Your
Yes.
tremendous urge to learn. You
Yes.
can, everybody can learn anything. And this
Yes.
is
Yes. I agree with you. Everybody has a great potential to learn. Deep, great potential to learn. They should, make use of that potential to learn whatever they want to learn. That's a great message you are given, Dr. Sanjeev, to begin with. Fantastic. Yeah.
Yes, sir. So till now, I have completed and done 1,200 cases of endoscopic ear surgery in different format.
That's huge number. Yeah.
I switched over from microscopic to endoscopic in 2012.
Okay.
I was not aware. I was not aware of this subspecialty of endoscopic ear surgery when I started. Just for my curiosity, I started canal incision, giving canal incision, and after few cases, I complete one surgery in November 2012 after 6 months of trial, hit and trial like that. And after that, when I did first endoscopic surgery in full format, then I realized that this is the best way to go without much of the tissue handling and the wonderful view of each and every corners of the and that was the journey I have started. And from there, I did workshop and I interacted many pioneers throughout this year and last in global. We have learned a lot, and that was again an eye opener for me in 2019 when the maestro of the pioneers of the endoscopic ear surgery given a very elicit presentation from different part of the world.
Yes.
And still I'm learning in this venture, and will keep learning in different format.
That was a bomb, super bomb, Dr. Sanjeev. You said I'm still learning. See, that is one humility we all should have. All of us should have. Yes, yes. That's a very important character a great surgeon will have. Okay. Yeah, pioneers. Yes, tell me.
So we can see the pioneers, and these are the still alive, and everyone is doing an excellent job, and everyone is doing new venture. And last lecture of the Marchoni I heard, transcanal lateral escalvage surgery, like removal of acoustic neuroma, stayed away from the internal acoustic matter through transcanal approach. That was again eye opener for me.
Yes,
so still endoscopic ear surgery is a long way to go.
Yeah.
But and these are the three pioneers of mine, close to my heart: R.N. Patil, Mohan Reddy sir, and Dr. Daniel Marchoni.
Yeah, yeah.
And still I learn everything, and I learn always from these very close.
Yes, I would like to say that the Dr. Patil, we go a long way together as friends. He's a senior friend. He participated in many of our ear surgery camps, which we conduct through Rotary, various parts of India. He participated in some of the workshop. And Dr. What's his name? Dr. Tarabichi. Okay. We had an interesting association. We both were invited faculty to Iraq in Baghdad. So we reached Baghdad, both of us, more or less same flight, I think. But there was a, because of security reasons and visa issue, we waited almost 7-8 hours in the waiting lounge to get into Baghdad city. Yeah, we have a fond memory of that. Yeah, please continue. Yeah.
One story of Dr. Patil and even Dr. Mohan Reddy told that in 2001, when he started presenting endoscopic Indo-ear presentation, they were radical like anything. And people went offensive for this subspecialty. Even he narrated one story in Nagasaki when Maus Tarabichi and the Daniel was in one panelist and Mario Shona in another panelist.
Yes.
There will be fight. There was a fight, great fight between these two group of panelists.
True. I know that story.
Yes, surgery have been having a very ups and downs, but I can say you clearly that endoscopic ear surgery is almost established in branch of otology in otology world. And I can say another thing that every surgeon is doing endoscopic ear procedure somehow, in some way.
Yeah.
So endoscopic ear surgery is a dedicated subspecialty of otology with legacy of 50 years of research, innovation, and publication, and ups and downs, you can say that. And a recent publication that is in 2018, Prince Mustafa Kapadia with the pioneer mouse Tarabishi.
Yeah.
They provide overview of endoscopic ear surgery, its development, principles, and penetration in otology in practice in 2002. And they reviewed all PubMed publication articles on use of endoscopy in practice of otology over last 50 years.
Okay.
Articles were categorized based on the date of publication and pattern and of utilization, the endoscope. And they also conducted identical email survey in 2010 and 2018 of otology use of endoscope and tabulated and compare the result. What is the result? You will be very surprised to see. And in this slide, the articles were very few before 1990. First of all, when you compare with the 2011 to 18, it is increased like anything.
Yes.
You say the long chamber of almost 283 is published.
Yeah.
So the growth of endoscopic ear surgery in terms of article publication in last 3 decades is tremendous.
Yes, true.
And the
certainly the evidence is building. I'm appreciating that. I'm following that. Evidence is certainly building in favor of endoscopic ear surgery. Yeah.
Even the use of endoscope in ear surgery, you can see there in 2010. Almost all the towers are lesser than the red towers, that is in 2018.
Yes.
So again, there is evidence that the growth of endoscope in ear surgery is tremendous. And one tower is very significant, that never use endoscope in ear surgery is decreasing like anything.
Yes.
So again, there is evidence, solid evidence about the endoscope, growth of endoscope in ear surgery. This is the educational activity attended by different delegates and in 2010 and 2018.
Yes.
And this is again a very significant growth. Attended hands-on cadaver dissection course in 2010 was 0. 2018, it is 2.10% increase. So you can see that. And both the educational activity and hands-on course is again very significantly increased. So not attended, of course, might be, I think the coming days, there will be again a very less amount of the surgeon who had not attended any educational activities in endoscopic ear surgery.
Yeah.
Again, cholesteatoma surgery, this is increasing trends from 2010 to 2018.
Yes.
So the thing is that if we have evidence, we have seen that the growth of endoscope in ear surgery is increasing.
Yes. Yes.
There is a need to standardize this thing clearly.
Yeah.
Cohen and Itel recently classify this endoscopic ear surgeon or surgery in these 5 categories. We can see that.
Okay.
Type 1 is 100% macroscopic approach.
Yeah.
Clearly. Now, type 1. I think I can say that every ND surgeon nowadays is type 1 endoscopic ear surgeon, because they used to see the ear.
Yes.
Office with endoscope only, and they document it, they print it, and they oblige, and that they can promote the science in different way. If you have evidence of the pathology for longer time, you can utilize this thing in your scientific research and your propagation of your science and your practice.
Yes, true.
And type 2B is at 50% microscope and 50% endoscope. Means when you are not wise with the instrument, you are dealing with pathology, and you are adding the instrument to to remove your pathology and remove your improve your result. That is the need of any surgeon, and that could with open-minded. I can say that only.
Okay. Okay.
Type 2A is 50% microscope and 50% endoscope.
Yeah.
I am a type 2B.
Okay.
I am at type 2B because I start my every year surgery with endoscope. It is a cholesteatoma, whether it's a advanced cholesterol, because what I target in advanced and complicated case of cholesteatoma, I target how to save the skin, skin first, and how to save the maximum healthy bone, because these are two precious things, can't be reversed.
The point to be noted: healthy skin and healthy bone. Yeah.
And type 3 for me, it is I have not done any type 1 tympanoplasty or type 2, type 3 osteoplasty in inactive year. Last probably even I used 3 mm scope in children at 7-year-old. Last 7 years, I haven't done any tympanoplasty macroscopically. Before that, I did many. So in terms of tympanoplasty only, I'm 100% endoscopic surgeon.
Okay.
I always raise a question, when this can be a very good approach, why to give a post-oral incision? Can be a universal consensus that type 1 tympanoplasty or meringoplasty could be done by endoscope only. This question is for you and other person also, that how we can search the possibility of this statement in near future.
Yeah.
So now, what are the variables of whatever instrument you are using, whether it is the endoscope, microscope? We need to see that all variables. And for vision and view, obviously, we have learned and this microscope established the otology surgery. And can't deny that. And they have binocularity, they have depth perception. The both hands are free in this microscopic approach. But we are here to propagate the science. Are you with me or not? This webinar is to propagation of science.
Yes.
And when the endoscope in ear is a powerful tool to propagate the ear surgery.
Fantastic.
You can't
statement.
That this is not a powerful. This is a most powerful instrument.
Yes.
Learn the anatomy, to orient the anatomy, to read the clinical pathological status of the ear disease. So what we can start from that only. And if you are comfortable, if you are trained much more for the instrumentation, for your endoscope advancement in the mesotympanum, you can do it. So maneuvering and compatibility is almost your learning curve and your choice and your interest, what you want to do.
Yeah, I agree with you. Absolutely. It is a great slide. Wonderful slide. Beautiful slide you designed. Yeah.
And working hand. For me, working hand, most of the surgeon, whether he is using endoscope or microscope, dominant hand is doing surgery most of the time.
Yes.
And the non-dominant hand is doing only suction. You agree with me or not?
Yes.
None of the surgeon having non-dominant hand working for the surgery and working apart from suction, doing suction all the way or the surgery is the only of non-dominant hand.
Yes.
So if I can say that what is the need to do repeated suction? So is it always necessary or is it always a compulsory? It means question is always with you that if you have less bleeding, your second hand will be just non-functional.
Dummy. You have a point. Yes, you have a point in that.
Second hand will become non-functional. Why not hold endoscope in that hand?
Yes.
Is it true or not?
Yes, you are right. Absolutely. I agree with you.
And for the instrumentation, please listen me. Whether you are doing microscope or endoscope, it doesn't make any big difference for the instrumentation. If you know how to use and when to use what type of instrument,
Mhm.
and where to where how it used in vital areas, how it could be used in non-vital area is
Mhm.
your. So again, this endoscope is not going to dictate you whether
Yes.
microscope or endoscope, then you should use this kind of instrument and how you should use. You have learned that already.
Yes. Yes.
And regarding the minimal invasive and cosmetic outcome,
Yeah.
obviously, what is the indication of laparoscopic cholecystomy?
Yes.
If there is a established method to open it.
Yeah.
You have learned in many subspecialty of this medical fraternity, everyone is doing orthoscopic surgery, the endoscopic, many endoscopic approaches is coming up, and they are only for minimally invasive and day care surgery.
Yes.
So why not in ENT?
Yes.
Can we go for that or not?
Yeah. Yeah.
We should think of that also.
Yes.
And regarding control of hidden areas and residual pathology,
Yes.
only one instrument,
Yes.
that is endoscope in mesotympanum, will do that.
Yeah. Yeah.
No macroscope will see.
Mhm.
If you have to see the hidden corner, you have to destroy all the structures, vital structures, which can't be reversed back. You can't buy that structure. You can't buy the same bone. You can't buy the same skin, healthy
Yes.
skin of the
Yes.
patient. Once you destroy by your
Yeah.
your desire to see the hidden corners.
Yes. No,
Are you-
really, they are the compelling reasons. You are a great advocate. Okay. Even if you're a lawyer, you would have been a great lawyer. Really, those are the compelling reasons, and anybody should agree with you. Great reasons. I really appreciate your flow of thoughts and this slide. Yes. Continue. Very nice. Wonderful. Yeah.
And for further innovation, last slide of one lecture I listened about the mouse, Professor Daniel Marchoni.
Yeah.
When he started dealing the very small type A acoustic neuroma,
Mhm.
what they did, the
Mhm.
team did,
Yeah.
they went to transcanal approach, transmeatal, and
Mhm.
they dissected the cochlea, and they removed because that was the non-hearing ear.
Mhm.
And between the vestibular and the cochlea, there is a bone. A state that bone goes to the internal acoustic meatus, and they
Yes.
remove the tumor.
Yes.
So with this innovation,
Mhm.
they started doing microscopic, started with endoscope.
Yes.
Endoscope invented the technique.
Yes.
They shifted to microscope for the many reasons, that compatibility and the other suitability.
Yes.
Mean to say that when endoscope is giving this kind of establishment of the cleverness, how
Yes.
to use your knowledge and your technique
Yes.
in mesotympanum for the benefit of patient, that
Yeah.
that could not be denied at all.
Not at all.
The future of this endoscopic ear surgery.
Yes.
There is no fight at all between microscope and endoscope. We
Yes.
are a ear surgeon, we are not endoscopic ear surgeon.
Yeah.
Are you agree with me or not?
Yeah, absolutely. Absolutely. Compelling reasons. Yeah. Yeah.
So,
Go ahead.
what could be the learning curve? Is it different from microscopic or it's same? For me, it is slightly the advanced stage, because one should always accept the limitations of any tools we are using.
Yes.
We have accepted that the endoscope, in spite of all the benefits, endoscope is having lack of binocularity and lack of depth perception.
Yeah.
So for me, if anybody asks me that how to start endoscopic ear surgery, I always say, have you operated with microscope? Well, yes. That it means you are a suitable candidate to start endoscopic ear surgery, benefit your patient, or improve your result, improve your acceptance in otology world. This
Yes.
is the I say that you should now do your endoscopic ear surgery, because we are not advocating endoscope by my ego. We are just dealing with the pathology, and we are just working for the patient benefit and the science benefit.
Yes.
So accepting the limitations of endoscope is the most important factor.
Very
If
nice.
want to start endoscopic ear surgery, they must accept that we are not here to replace the microscope.
Yes.
We are here to search the possibility in benefits of patient and the science.
Yes. Yes.
So you start with both microscope as well as endoscopic.
Yes.
One is also important. If you have luxury to fresh frozen specimen,
Yes.
you nicely the tissue handling training with the endoscope, how to raise the flap, how to see the corners, how to apply the angle endoscope inside the mesotympanum to see the different hidden corners and the important anatomical landmarks.
Yes.
That is very important. And for simple endoscopy procedure, everyone is doing OPD diagnostic otology. That is not a big deal.
Yeah.
But you should start also some minor procedure like wax removal, stability of your instrument and your manipulation hand should be very stable. You should start with meningotomy, type 1 tympanoplasty with wide canal, left ear and posterior base perforation. This is very important.
Yes.
If anybody want to do tympanoplasty with endoscope, the first case should be left ear. Ask me why left ear? Of a right-handed person, I am saying that.
Yes.
Left ear, they should start, but the surgeon should be right-handed. Why? Because there should not be any crossover during your first case.
Yes.
You feel very comfortable with the endoscope and instrument inside the narrow canal, even lesser space canal, because you have done in nose. Nose is a bigger space, entry is bigger than the any externality meatus. So you may be comfortable at in nasal surgery, endoscopic nasal surgery or face, but if you start posterior perforation, wide canal, left ear of a right-handed surgeon, it could be very comfortable and you will gain confidence and then you will advance your skill after this basic procedure type 1 tympanoplasty.
Fantastic. That's a great tip you have given, Dr. Sanjeev. I really appreciate that. Yeah. It's a great tip for the beginner.
Yes.
I'd like to explore this here.
And again, the advanced endoscopic surgery, you can do it right ear, left ear, anterior base perforation, large perforations, total perforation, fish out technique, underlay, interlay, overlay. Even the new term is total excision of annulus. You can do everything with endoscope. There is no that total excision can't be done by endoscopic approach. Cholesteatoma surgery you can do, but there is an indication and contraindication of cholesteatoma surgery. You should know, because what are the stage of cholesteatoma which can be dealt with endoscope, and you can add imaging to plan your surgery beforehand.
Yes.
And for revision surgery, obviously, I always do my tympanoplasty with endoscope only. Even I did a few of my series, even not much, but up to 50 of different. It's not my revision, but somebody has did, and because of some reason they fail, and then I did entirely with endoscope. Yes, harvesting of temporalis fascia could be slightly cumbersome, and we did it from other side and then tympanoplasty from this side. So that could be one reason to shift with microscope, the same side incision like that.
Okay.
And as surgery, obviously I improve my result with endoscope, not only by endoscope. There are many things in stapes surgery to improve your result. What you are able to see as a cinematic effect in a very small area to work, you must be convinced that this is the way to go.
Yeah.
So this is the learning curve. It could be for many beginners and even the juniors. And if they will go, they will certainly gain confidence in this way. So what could be the principles of ear endoscopic ear surgery. And this
Yeah.
is ear surgery, endoscopic ear surgery. Any surgery must have planning and preparation. Otherwise, you can't be very comfortable in your surgery. Anyhow, you can complete your surgery. And the rest 3 is a very balanced principles. I think removal of disease, preservation of healthy tissue, and reconstruction all
Yes.
go hand by hand.
Yes. Yes. Very nicely depicted. Fantastic slide. Wonderful slide. Yeah. Yeah.
Because if you are not aiming reconstruction and you are going removal of disease without considering reconstruction,
Yeah. Yeah.
you will certainly land up in a situation where nothing will left for reconstruction, your sustainable reconstruction.
Yes.
So reconstruction should be aimed as early as possible, and preservation of healthy tissue depends upon your aim, how you aim your reconstruction.
Yes.
And then you start your surgery.
Yeah.
I say this could be a very good approach to give sustainable reconstruction. This is my take. And now steps of endoscopic ear surgery or tympanoplasty, you can say. The canal access is the most important and first approach, choice of approach. That could be many double door approach is mine approach, bone removal. In even tympanoplasty, you can remove, and how you will remove the bone, how much you will remove, what instrument you will need to remove the bone. Removal of disease is always important, even in tympanoplasty, until unless you deal with the ventilation pathology, you can't. Visualization of extent of disease is always important, and according to your removal of disease, your removal of healthy tissue and reconstruction. So,
Yes.
so for canal access, this is very important for me. You have canal, you know, the anatomy, outer part is the hair bearing area, inner part is the bony portion, and inner part is a surgical site.
Yes.
To work there. But you have to cross this external part, lateral part,
Yeah.
and then only you will reach there.
Yes.
So passage should be clean and wide.
Yes.
Okay.
Yeah.
Otherwise, again, you will struggling in passage only. How can you go and perform surgery when you are struggling going to the site?
Yeah.
So one thing is that how to make the canal straight, one thing, and another thing is how to remove the hairs for clear view.
Yes.
So we can have 2 options, manual or chemical. I am running this video, both videos simultaneously.
Okay.
And you can see, because when you are using any chemical, you have to test your sensitivity, whether this chemical is going to suit the particular patient or not. So you must check that sensitivity. This is a chemical, brand name is B, and everywhere is available, and everyone is must be knowing about that.
Okay.
And after checking its sensitivity, what should be the method of application of this chemical?
Yeah.
First of all, we must avoid, because we are having a perforated tympanic membrane. That's why we are going for surgery. And if we have perforated ear, it means the loud window is open. We can have a chances of toxicity of any drug.
Yes.
Even in adrenaline absorption, even in you are giving washing, and even spirit, they are going inside the middle ear.
Yeah.
So to avoid these all the complication by the chemicals,
yes,
first you should pack your medial of the canal very small cottonoid ball,
yes,
either with normal saline or even dry. The normal saline soft piece could be okay, and there should be thorough gentleness there, and the should be always small. Why? If you have a greater size, bigger size, you will force to push this very forcefully,
yes,
and injury.
yeah,
Once you insert the canal, before preparing your canal, there will be bleeding, and that bleeding will not going to stop even after injection or after packing of anything.
yes, you're right. Mm.
So you should pack it and then apply chemical. Application duration of application could be 3, 5, 7 minutes. That all depends upon the content of keratin in the skin and hairs.
Yes.
That all that have to assess before.
Yes.
And ultimately you will get this much of this clearance.
Yeah.
And here is still we are at the end of procedure. We are struggling for removal of hair, and during this procedure the chances of getting injury of external part of the ear is very high.
Yeah.
And if you injure, then they start beeping and going the blood inside, and you're hurting there, and your whole surgical field will be spoiled.
Yes, you'll get disturbed. Yeah.
Preparation of canal external hair bearing area is first.
Yes.
And how to prepare the surgical side, because surgical side is your again a very important area of work, and you will doing everything there for last 45 minutes, for 40 minutes, whatever approach you are doing it. So you have to prepare that also, and that is very, very important. It could be at local and general anesthesia for the pain purpose, but for local or general doesn't make any difference. You have to prepare for at least bleeding less area.
Yes.
When you start taking incision, it could not bleed much, and even not bleed a slight. I can say that only.
Yes, very important. Yeah.
So choice of anesthesia is not at all important for endoscopic ear surgery. That is just any surgery, that could be general and local. But when you decided to do ear surgery and you are doing endoscopic ear surgery, there should not be any bleeding, because we have committed that we have only one hand to work.
Yes.
So this is a special preparation for me in any age group, and even in morbid condition also.
Yes.
I had 1 ml of 1 in 1,000 Adrenaline in 30 ml of Xylocaine, 2% Xylocaine, and that become 1 in 30,000.
Yes.
And if there is a comorbidity with higher age group like 65 and with the cardiac issue, we can dilute it up to 160,000, 1 in 60,000, half ampoule of Adrenaline we can add. Okay.
Yes, perfect. Yeah.
And injection, 4-quadrant injection is not new. Everyone is knowing. So during injection of infiltration of the local, this freshly prepared 1 in 30,000 Adrenaline with Xylocaine with Adrenaline, you must take precaution, avoid bleb inside the canal.
Yes.
Otherwise, again, there will be bleeding and you will be going to struggle during surgery.
Yeah, you're right.
So you should stick to your bone and apply the speculum just to infiltrate towards median.
Yes.
And you all know this thing. This is not new.
Yeah.
1 in 1,000 after infiltration, you must pack the medial portion of the exonotic canal with 1 in 1,000 pure Adrenaline, a small cotinoid ball, for at least 20 minutes. Why 20?
Okay.
Because half-life of your Adrenaline is 5 to 10 minutes. So you will get maximum effort between 15 to 20 minutes at least.
Okay.
Wait. So for me, it is a minor procedure room taking in major procedure room.
Yes.
And that could be preparing slightly, very with caution. You should have a monitor, everything you should have a
Yes, like any other surgery.
Like any other surgery.
Yeah, yeah. That's very important. Yeah, yeah. Yeah, yeah. Dr. Danya is asking, could you please repeat how you prepare that solution 1 in 30,000?
Yeah, repeat. You have 30 ml of available Xylocaine, 2%?
Yeah, 2% Xylocaine. Yeah.
and your Adeline,
Yes.
what you are getting in market
Yes.
is not 100%. That is 1 in 1,000.
Yes, 1 in 1,000. Yeah.
So
Add that 1 ml to this, right?
1 ml to the 30 ml, it becomes 1 in 30,000.
30,000. Perfect.
And it's not available in market because this is almost 1 in 80,000, 1 in 2 lakhs, 1 lakhs available.
Yeah, 1 in 80,000, 2 lakhs available. So we'll have to prepare ourselves. Yeah.
Freshly prepare inside. Even you can prepare. That is very vital. Otherwise,
Yes.
somebody is prepared and they forget to add something mishap has happened. Again, you inject it. Again, you will be in loss.
Yeah.
So
You can prepare yourself on the table. Yeah.
Or in front of you, somebody else can do.
Yes. Yes.
This is again an important
safe thing to do. Yeah.
So this is a video of doing this preparation. We have prepared the canal and applying the bead, and there's a small cottonoid ball we are pushing inside the canal. Just a cottonoid ball soaked in 1 in 1,000 pure Adeline, we can say that.
Yes.
And doing very gently. And that could be in microscopic approach. Mind it.
Yeah.
It's not with naked eye or a headlight.
Yes.
Always do with microscope. These all infiltration and the packing and the cleaning of canal.
Yes.
This is again very important. Otherwise, you will not able to prepare your endoscopic ear properly.
Yes.
Because you have to avoid injury, you have to clean properly, you have to avoid the toxicity go inside the middle ear, and your infiltration and your packing with a sock ball could be almost perfect without any injury inside the canal.
Yes, very important. Yeah.
So we can have a fast forward things, and ultimately, and this packing up this way will give two purposes. One is decongestant, and if you have infiltrated the canal with a slightly larger amount of the xylocaine, that will spread.
Yes.
And you will get ultimately a wide canal.
Yes.
After 15 minutes.
Yeah. Yeah.
This fulfilling two purposes here.
Yes. Yes.
Now that has canal access has done.
Okay.
Now approach could be my approach is double door approach.
Okay.
And what is the double door? I will depicting you first by diagram, and then I will be showing you the video.
Yeah. Yeah. You are the pioneer. Yeah, we're eager to learn from you. Yes.
And this is the pressing of margin is not much important. Everyone is doing.
Yes.
Double door is a start from here.
Okay.
Okay. So we have, and before taking this incision, I have to say that this double door approach is from anterior to posterior approach. Okay. One thing is very clear. And what we have anterior to posterior, you must know. The spread of medial cleft is from anterior to posterior. You are agree? Medial cleft start from the scission tube. Yeah. And go back to the mastoid tip. Yes. Again, the spread of medial cleft is from anterior to posterior. Yes. What is that also? Histological division. Antero-inferior and posterior-superior. Yes. What is antero-inferior? The ciliated, non-ciliated aspecific cells. That is for ciliary function. Yes. And what is the posterior-superior? Is a flat cell having breach of vessels that for gaseous exchange and buffering. Yes, you are right. Absolutely. And you must be agree with me, when you see your OT of endoscopic ear surgery, you are sitting and your monitor is from anterior to posterior. Okay, that makes sense. Yes. Your monitor is anterior and you are sitting posterior. Yes. So you must say that anterior to posterior, even your cholesteatoma is spreading anterior to posterior. You are right. Any cholesteatoma coming from mastoid tip to a major tympanum.
Yes.
No, never.
Yes.
Your pathology is going this way. Your ventilation and ventilation pathway, even a ventilation pathway, there is two compartment, anteroinferior compartment and posterior superior compartment.
You are right.
And divided by a diaphragmatic epitympanic diaphragm.
Yes.
And the tensor fold, anterior tensor fold and posterior many folds, like posterior medial fold, anterior medial fold.
Yeah.
There are many folds. So again, there is anterior posterior relation.
Mhm.
Physiology of the anatomy and your surgical procedure.
Yeah.
And your pathology also going anterior to posterior.
Yeah.
So there is a valid reason to approach anterior
Yes.
to posterior.
Okay. Interesting. Yeah. Only the drainage is in the reverse direction, posterior to anterior.
Yeah, you can say that only.
Yeah. Yeah.
So this is anterior incision I am taking, and that could be up to 8 millimeter from bony annulus and from 12 to 6 o'clock.
Mhm.
It's big incision you must take, and you make a big flap, tympanomeatal flap.
Yeah.
And when you proceed after taking incision,
Yes.
you will be here to open a wide anterior door,
Yeah.
right from the 12 o'clock to 6 o'clock.
Yes.
Okay.
Yes.
What will serve this purpose, this wide anterior door? It will provide you the inspection of anatomy as well as your pathology.
Yes.
Okay.
Yeah.
You can reach up to the isthmus in protympanum.
Yes.
You can see the supratival area also. You can
Yes.
read the anatomy, tensor fold, type of tensor fold. It is partially
Yes.
blocked.
Yes.
Because you are doing surgery not for the tympanic membrane formation only. You are doing the surgery. Tympanoplasty is the establishment of physiology also.
Yes. You're right. Absolutely. I agree with you.
So anatomical establishment, making anatomical structure is not enough during tympanoplasty. You have to establish the physiology.
Yes.
So that you have to try to see the ventilation obstruction and correct it during your surgery.
Yes.
So with anterior approach, you can see the anterior compartment very clearly.
Yes.
And after making this wide anterior door and you can start doing posterior incision. And this incision is slightly far lateral from the anterior incision because we are here to avoid the full cuff elevation.
Yes.
One thing is very important. It means if you have taken 5 mm incision anteriorly from annulus, you should take at least 6 mm, 8 mm, whatever, but you can't go the same line.
Yeah. Yeah.
Otherwise, there will be full cup elevation and disorientation of flap during surgery.
Yes.
So after taking this again 12 to 6 mm, because and you should start with sharp instrument from superior because superior is thicker one.
Yes.
So you need greater force and greater stability of your instrument, and you should start from superior to inferior and with sharp instrument. And after taking incision again, you will opening the posterior door.
Yes.
And after opening the wide posterior door, then again need to do something else.
Yeah.
You have to superiorly, you have to denuate your malleus, or if you are not denuating, you must go till the lateral process of the
Malleus.
or open the Prusik space most of the time.
Okay.
That could be up to that extent. And inferiorly, if you go superiorly, in that way you are able to denuate your malleus clearly. And there is a video how to denuate the malleus safely. I will. And after opening the Prusik space and denuating the malleus, your superior margin of posterior door going to merge with the superior margin of anterior door. It means you have elevated the annulus and the adjacent structure almost clear through clear 360 superiorly, try to 360. If you did, you will do it inferiorly also. And inferiorly again, the inferior margin of posterior door must be merged with the inferior margin of anterior door. And ultimately, you will able to raise your fibrous annulus from bony annulus almost 360. Okay?
Yes, yes.
But there is a tympanomeatal flap attachment at superior and inferior.
Yes.
State. And it will
So the vascular strip is preserved. Yeah.
You will avoid a full cup elevation,
Yes.
and your flap orientation will be tremendously good throughout your procedure, and you can park your flap. You can take mechanical advantage of that flap, larger flap, whenever you want to work, either anterior or posterior. Flap reciprocally.
Yes.
Park your flap reciprocally.
Yes.
And all the vital structure which is lying in the posterior part, posterior superior part, you will see clearly without any obstruction.
Yes.
So why larger flap, tympanomeatal flap, and why double door approach?
Yes.
The answer has been given already. Any questions at this stage? We can answer. We will happy to have answer.
Yeah. No, you have explained so well. I don't think anybody has any questions. Friends, if you have any queries, please feel please feel free to ask questions. You can raise your hand or you can post in chat area. Okay. No, you have explained very nicely. Yeah.
Can you go ahead now?
Yeah, you can go ahead. If somebody has questions, we'll come back.
Inspection of pro tympanum. We can see that. We can see that. Can you have any idea about the narrowest and the narrow isthmus in the medial cleft? That anterior it is Eustachian tube isthmus. Posteriorly, we have anterior isthmus, posterior tympanic isthmus, and that is anterior tympanic isthmus between the pendule of malleus and incus, long process of incus. And the posterior tympanic isthmus is between long process of incus and your scrotum, like a posterior bone.
Yeah, posterior tympanic system. Yeah.
So these are the three narrowest place. And one thing is very important. What I observe in you must be agree with or not. Medial area has very strong prediction to form a very stable tag. In any assault, you start forming tag and some bands. And if you don't remove at earliest time, the earliest your pathological time, there will be fibrosis in this tag, and there is a memory of this fibrosis. So even adhesive otitis media, if you have not significantly preserving the mucosa, again the adhesive band will be going to happen.
Yes.
So I think in my observation, these two important things very prone to make tags and bands, and they have memory.
Yes.
Start again and again. So after doing all this double door approach, making anterior and posterior door, merging it and making it lifting of 360 annulus, fibrous annulus, of the malleus, we can repose the flap and just see the amount and the size of graft we need in perforation, the small perforation, posterior base perforation, total perforation. That all depends upon what size of graft and what type of graft. Type of graft is not a matter of discussion here, because for me, I was started with everything, cartilage, pericardium, and I left all cartilage and pericardium. Now I am just doing with temporis fascia. For last 700 cases, I am doing this also.
Okay. So the flap is the graft is harvested only after raising the flaps.
Right?
So okay. Makes sense. Yeah.
This is a perichondrium based flap, and I am putting it. I am going through the posterior door and coming out from the anterior door, and then we will get this much of the at the end.
Okay.
No bulky dresses, no bulky bandage and everything. Is simply, you can say that is non-invasive and cosmetic too.
Yes, absolutely. I agree with you. It appears as if you haven't done any surgery.
Okay.
Very nice.
So now this is a video of the double door,
Yeah,
and
yeah.
having this double door, because I think every surgeon
Yes,
start his career with tympanoplasty, and you have chosen a very basic topic. If
yes,
everyone is doing perfectly,
yeah.
the scientific commitment will increase and the
Yes,
profession
yes.
will increase.
See, this is a bread and butter surgery. One of the commonly performed surgery in ENT is
Yes.
tympanoplasty, maringoplasty. I encourage every surgeon to master this surgery. All ENT surgeons. See, particularly in India and even for that matter, third world countries, we
Yeah.
have huge population with
Yes, sir.
with the CSYM. I have calculated, I have taken the statistics. Each ENT surgeon, even each and every ENT surgeon is operating ear surgery. We have about 28,000 cases for ourselves for each ENT surgeon. But unfortunately, not all of us, do ear surgeries. Okay.
Yeah.
Many people, they have become endoscopic sinus surgeons or rhinoplasty surgeons or something. Only a fraction of ENT surgeons are otological surgeons. So that means number is even huge. There may be more than 50,000 or 1 lakh surgeries per surgeon. Okay. Yeah, this is one surgery you must practice. Yeah. Yes, go ahead.
Video. Let's see what I have given you.
Yeah.
I'm just doing it in this way. This is a fast forward, likely 2 times fast, because we have to complete all the procedure and the surgery. So here we can see that we have already prepared. Still there is some blab anteriorly, but bleeding is almost nil.
Yeah, yeah.
There is no bleeding at all.
Yeah.
And when you take incision from 12 o'clock to 6 o'clock anteriorly, during the raising of flap, there will be less bleeding. And if any bleeding is not very worried about, you should use cottonoid ball, soaked in Adeline, pure Adeline, and that will serve 2 purposes. One is a mechanical, that will give you a space to work, and other is the hemostasis. So this way, I'm just making anterior door, complete anterior door. We have a look of protympanum. We have given us some ball-like things in there. And again, the posterior incision, I'm taking just far lateral from the anterior incision.
Yes, sir.
And this big, larger flap is very important.
Yeah.
It will give you a space to work without hindrance. You can park it interiorly, and anterior can be parked posteriorly.
Yes.
With using an extra hand, an extra instrument to do that.
Yes.
Because your suction is doing this thing also. They are in macroscopic.
Yeah, yeah.
You must be agree with that. And this cottonoid ball is taking a very leading role to complete it. And here this is a very actually I'm just stopping here.
Okay.
This is fast forward video. So this is slightly taking you this denuation of malleus is a way. You can see that, but actually it is not.
Okay.
Because when you see anything fast forward, it looks aggressive.
Yeah, yeah, yeah.
But for me, the denuation of malleus is a very wonderful things how to do.
Yes, yes. Very important.
I have to see that what is the stable structure of handle of malleus. That is the neck. Neck is most stable structure.
Yes.
And after opening the prosthetic space, you should expose lateral process of your handle of malleus. And one of my video in YouTube, and just again I'm just repeating it. I learned about the malleus, anatomy of malleus. And what is the malleus? Malleus is a obviously bone, but a core of cartilage is covering the malleus, and core of cartilage is forming the lateral forces. That is why there is some specific name of the lateral forces, that is cap. You must be remembering about.
Yes.
So this malleus is covered by perichondrium, not the periosteum. Okay.
Okay.
And we need to just take incision over the perichondrium while denuating.
Yes.
And you take incision in perichondrium. There is a confluence of this fibrous tissue very firmly at the level of umbo.
Okay.
And there is a cap-like fibrous tissue. So you have to uncap either from posterior, superior to inferior, in anterior way or posterior way.
Yes.
So you have to circular sweeping over the umbo.
Yes.
To uncap that fibrous cap situation.
Okay.
Then only you will be in situation where you can say that I had not left any kind of fibrous tissue, and you must start suspecting that any epithelium is left or not.
Okay.
So this much of this denuation you need to require. Always you will able to see without any fibrous tag.
Yes.
And you can see that there is an osteolar continuity is
there. Yeah.
And anterior, we went there from posterior, and we will come out from anterior. Why this is anterior door is also important. When you just push your tympanic temporis fascia or any graft, chances of getting inside the cystian tube will be high.
Yes.
Or if you have not raised that flap, you will not able to sure that whether this graft is sitting over the anterior canal wall or not, or is inside the cystian tube. And ultimately, in post-operative period, there is a substantive obstruction, and you will get failure. One way. And another thing is that we work the immediate success of tympanoplasty is the only when you have early vascularization of graft.
Yes.
Must we agree?
Yes. Yes.
Because up to 3 to 4 weeks, your graft has to vascularize.
Yes.
And then after, you will be very sure that ventilation is establishing or not at established.
Yes.
And for that, you add some drugs, or you do start asking for the Valsalva. Okay.
Okay.
For the early success, it means taking off graft is very important. It means early vascularization is very important.
Okay.
And for the early vascularization, we need supporting tissue to give blood supply to the graft material. And what could be the supporting tissue? Obviously, the bone is the most important.
Yes, very important. I agree with you. I am of the same opinion.
The most important is blood supply to the graft.
Yes.
Or when it is giving from all the corners 360.
Yes.
It means you are providing a space for early vascularization in maximum level.
Yes.
Okay?
Yes. Absolutely. I agree with you.
Another structure is giving blood supply to your graft material is the residual tympanic membrane and tympanomeatal flap.
Yes. Yes.
If it is supplying even lesser extent,
yes,
your tympanomeatal flap must be vascularized.
Yes.
And that is why
Yes.
we avoid full cup elevation.
Yes.
One thing is that.
Yeah.
Because one of my video where when I zoom it, the blood circulation of mesotympanum, teeny blood circulation, the blood circulation, the direction of blood circulation from superior to inferior. Okay.
Yeah.
That is why many of surgeons doing superior base flap tympanoplasty in endoscopic ear surgery, or I am preserving extra strips inferiorly also. Just
okay. Yes. to double vascular strip, double flap and double vascular strip.
Double.
Fantastic, fantastic phenomenon.
And then you will get early vascularization. Once your flap vascularized fastly before it will necrose.
Yes.
You can say that my tympanoplasty is successful at 2 weeks of your tympanoplasty.
Yes.
Your eye will be happy when you examine the your neotympanum with a microscope or endoscope, having a very vascularized, very vascularity going to establish in big bay. And then you start managing to establish the ventilation.
Yes.
So one thing is that important here also. Why I'm putting Abzal in middle ear?
Okay.
Because there should be a firm attachment.
Hello. We lost your voice. Hello. Dr. Sanjeev, we lost your voice. Are you there? Yeah, I'm sorry. There was some problem. Yeah, go ahead. Hello. Dr. Sanjeev, can you hear me? Hello. Hello. Can you hear me?
This is a piece out technique. Yes, I'm going.
Okay, okay.
The underlay placement of graft. Are you getting me? Hello, sir.
Yeah, I had some connectivity issues. I'm fine now. Okay. Can you hear me?
Yeah, I can.
Okay, fine. Okay.
So this video is for piece out technique where you have a large perforation.
Okay.
Large subtotal perforation where there is chances of getting anterosuperior residual perforation is very high.
Yeah. Okay.
How to avoid that? In this way, you can avoid. Take a rectangular big graft. One thing is very particular. When you are taking big graft in endoscopic ear surgery, many of my colleagues are asking about your management, how to manage a big graft. What is the advantage of larger graft in tympanoplasty? So larger graft, there is many advantage of larger graft because you will get a 360 vascular, getting a space for vascularize. One thing, but manipulation of big graft is again a very, very tough task with a single hand.
Okay.
So you need to learn this also.
Yes.
When you hold your graft entirely with any crocodile forceps, just negotiate to get it a right place there.
Okay.
And then when you reach the appropriate site, you just do it with a sickle knife or needle, curved needle.
Okay.
And this fish out technique, I have made a hole in a superior portion of the graft between anterior 1/3 and 2/3 junction. I will make it for the handle of malleus manipulation. And with this orientation, I am just doing it clearly. I can see that this hole is here. And with single hand, we can do this thing. No need to extra help, no need to have extra hand to help this. And this fishing out of the handle of malleus. And this hole is going to fix just superior to the lateral process of the malleus.
Okay.
So it will be high, and you will be avoiding the anterosuperior and posterior-superior gap between the graft and the tympanomeatal flap and the residual tympanic membrane.
Yes.
So that way you will avoid anterior, because many a times we have seen that in large total perforation, if your graft is rectangular and you have not denoted the handle of malleus, you will have an anterosuperior residual perforation.
Yeah.
For that, you always do, you must do this technique, fish out technique, to avoid.
Okay.
And this is again, if you feel that there is a much of the abscess inside the middle ear, you can remove according to your need.
Yeah. Yeah.
And again, making of anterior recess is very, very important. Anterior recess, because when you lift the anterior flap and you are making the anterior window, you have liability to the anterior recess to avoid anterior. And this way, we can make anterior recess with a particular intention to just place the fibrous annulus towards the bony annulus as close as you can.
Yes, yes. It should be reposited to the exact position to prevent the anterior blunting. Yeah, very important. Very nicely demonstrated, Dr. Sanjeev.
And
very
this
nice.
is final look.
Yeah.
So now, what is the Banthro's space there, and why this space is very important to take care during your surgery? You can see the boundaries. You can see anterior epitympanic space, superior epicular space, space, and there is a posterior pouch of Banthro's, anterior pouch of Banthro's.
Yes.
I'm narrating this by this video. When you are going to do any tympanoplasty, you need to fill this space widely, because in this space there is a two isthmus, anterior and posterior isthmus, and you need to clear, because if there is a tag and there is a band in that there is space, and this dilation, obstruction, and again retraction, and you may get a failure. So to clear this this Banthro's space, we always have this anterior isthmus we have. And posterior isthmus we need to clear. So we remove the bone first. A slight bone removal, posterior here. A very gentleness, we require very gentleness, because the chorda tympani, as well as you are lateral to the vital oscles. To avoid dislocation and opening of that.
Yeah, Dr. Sanjeev, are you there? Hello.
In this procedure, the flap with epithelium and the annulus is still there, and the mucosal layer is still there. So after elevating the flap, are you getting me, sir?
Yeah, I'm getting. What happened? I had a break in the net in between for a few minutes. It's okay. Go ahead.
So I already told that the double door approach is approach for everything. So you can do total annular excision also. How I am doing it, just see, because this is a popular technique nowadays. That there is a papers already published by Pavan Singhal. Suri is very fond of this total annular excision. I think it should be also with the endoscopic approach, and in double door is very suitable for that. So here in this video, you are seeing that both video are just I'm giving you anterior and posterior. And after reaching the annulus, we should just slightly, not a very forceful to lift the annulus. We should lift the epithelium only,
Okay.
and we should try to avoid the lifting annulus. And this is a simple way we can again do it in 360 manner.
Yes.
Okay.
Yes.
And just posteriorly, I'm just lifting the epithelium and leaving the annulus and mucous layer there only.
Okay.
Okay. And after elevating the epithelium and 360, you can just take out the total annulus with a mucosal layer. Okay.
Yes. Yes.
But I think this is the not the total annulus that Dr. Suri Prabhu is talking about, the Pavan Singhal is talking about.
Yeah.
I think you must be agree that the in that perspectives, total alveolar excision means the excision of skin along with the annulus also. But
Yes.
here I am,
And all the remnant tympanic membrane.
yeah.
Yeah.
So I am here preserving the epithelium.
Mhm.
After just doing it in this video, again, you can see putting the prosec space from superior to inferior,
Mhm.
and clearly we have seen that. So now we are free to remove this annulus as well. And after removing the annulus, we can place the graft over the handle of malleus or under the handle of malleus, whatever choice you have.
Yeah.
It's a flexibility in this, and in this approach, you can do everything. I am telling again and again. Even stoma surgery, I can give you. You can make a window without any obstruction with this double dot flap.
Okay.
And this is just again after giving. So so for me, just I have some soft corner towards the and fibrous annulus, because
Yes.
sir, you knowing that there is a elasticity of the fibrous annulus. You exercise it,
Yes.
it will even in cadaveric situation, it will okay.
Yeah.
It can't be a straight, even cadaveric situation. Are you agree with me or not?
Yes.
So
Yes.
there is a
You're right.
tensile strength fibrous annulus, and there is a elasticity.
Yes.
So if you are elevating the anterior flap for the benefits of your graft vascularization, as well your removal of pathology and your placement of graft, you need to have this much of fibrous annulus to make it a anterior and post inferior recess properly. Otherwise, you have to do a lot of precautions to make anterior recess in this case, because we don't have that much support of us to make anterior recess. And the chances of getting blunting in when you have removed the fibrous annulus.
Yes.
But I did it, and in post-operative period, I didn't have any anterior blunting in this case. But ultimately, you have to see the greater result. The way is not important how you are doing. You must see the max, and how to improve yourself with your mistake is very important.
Yes. Yes. Learning from our mistakes is very important. Yeah.
Ultimately, you will have a very wonderful look of your neotympanum.
Yes.
Just nothing has happened. It's fresh and has tone of light. Okay.
Yes.
Just you take every corners.
Yes.
Your flap is not buried with other flap. Your tympanic membrane having not any residual gap. You should see. Just give some extra time, 2-5 minutes. And this is the pushing of the rectangular gel
Yeah.
to keep the anterior recess slightly deeper as normal.
Yes.
This is
Very
another
important.
procedure.
We must create an acute angle there. For
Acute
normal,
angle.
yeah, to establish normal layering. Very important. Yeah.
Anterior recess, avoiding anterior blending is very
Yes,
important.
very important. Yeah.
Now, in difficult situation, so what could be the difficult situation? Next questions would be must be answered before dealing with difficult situation. Difficult situation means, first of all, your perforation is almost anterior based and your canal is tortuous. It means even in canal is tortuous or your perforation is posterior, you can manage. Canal is tortuous and very cut canal, there is a lot of anterior bone hang and inferior bone hang, and your perforation is anteriorly based and sometimes larger perforation. So how you will manage? Okay, and here I can answer the questions. What endoscope we need and what length of endoscope we need.
Yes.
If you listen many lectures and many discussion, panel discussion, everyone is telling that the shorter one is good and the thinner one is good. But for me, in my 1200 cases, I hardly use 3 mm shorter, 3 mm in diameter and approx 15 mm, 15 cm of the endoscope telescope. Why? Because if you are doing ear surgery, like your face, your endoscopic hand, your instrument, is almost keeping throughout procedure of centimeter and the inches apart.
Yes.
You must be agree. Even sometimes 6 inches like apart, sometimes 4 inches, 2 inches like. But when you are doing endoscopic ear surgery, your two hands, the endoscopic hand and your instrument working very closely.
Yes.
And when if you have a longer length of endoscope and like 18 centimeter regular telescope, most of the time you will get collide of your both. Okay.
Yes, absolutely.
During procedure. So if you have a larger working space, then chances of the collision of your two hands will be less. And that will only happen when you have a longer length of telescope. At least not longer than 18 centimeter, but not lesser than also.
Okay. You have a good point there. Right point there. Yeah.
Okay.
Yes.
And your instrument again have longer shaft, taper a longer shaft. Then only you will able to work in mesotympanum, because you have to work in mesotympanum. Only raising of flap is not important in endoscopic tympanoplasty.
Yes.
After your margin, raising of flap, majority of work inside the mesotympanum. You have to go medial and medial.
Yes, you're absolutely right. Yeah.
So until unless you have a working space, you are not able to work properly. That is by one example in Delhi, Max Saket. I was used to use a regular telescope and regular instrument. Might be my training, my learning. That workshop has given me the Sanjay Sardebas have given me the Panetti instrument and the Panetti scope, CMS scope 3mm. It was very difficult for me to complete the procedure, and then I left and I just start with the regular one. I comfortably did that. But in difficult situation, what is happening here?
Yeah.
You are not able to do curved canal because your hand and your working hand, your instrument, endoscopic hand is just colliding when you are going medial.
Yes.
If you are doing endoscopic surgery in curved canal, you haven't a space to work because you are always your endoscopic hand is coming your and collide with your instrumentation hand.
Yes.
So what you need to do, you keep your scope, tip of your scope at the outer part of your canal.
Mm-hmm.
How to see that the medial part? It means there should be another procedure, another tricks.
Mm-hmm.
You should do maximum zoom in situation,
Mm-hmm.
as if you are very close to your structure,
Mm-hmm.
and find focus and hold your instrument a slightly far in softer respect. Your shaft should be a longer one, and you keep the lateral it means far away from your working end of your instrument.
Okay.
Again, your instrument length inside the middle ear will be high, inside the canal it will be very low, and you are keeping your scope at the tip of your external canal meatus in highest zoom situation, able to see each and everything. And when you have a space, you can get through your curved canal also very easily. In this case, you can see.
Okay.
Situation. And even your this is a curved canal. Okay.
Okay.
Here I used one technique. I hold the shaft slightly just far from the mid position, length, middle length, and just going meticulously, and my endoscope tip is not going very close to the working surgical side.
Yes. Yes.
And if you need more visualization, clear visualization, you do it zoom in situation, and then you'll be able to reach there.
Yes. Yes.
The person is saying that only a straight canal can be done with the endoscopic approach and single-handed approach. That this is not true. I am regularly using this trick to get through this curved canal.
Yeah. Yeah, that is one technique we can use. We can zoom in. Yeah.
Yeah, zoom in. And in this the situation, no microscope, in transcanal approach, without canaloplasty, they can't see the inferior portion. Agree with me or not?
Yes, I agree with you.
Without, even in open approach, without doing canaloplasty, you can't see the inferior of annulus in this case.
Yes.
Yeah, you can see that.
Yes.
You can see that.
Yeah.
With the use of this cottonoid ball, we can see the inferior portion of the annulus beyond the bony overhang without doing any canaloplasty. It means if you are able to see in this way, your almost your all areas is controlled with endoscope.
Yes.
The advantage of endoscope you can imagine.
Yeah, I agree with you absolutely.
Just see. We are near to annulus, and we will elevate again 360 even in this situation, where any microscopic approach need canaloplasty to see that.
Yes.
I'm holding from midpoint, far midpoint. Okay.
Yes. Yes.
So your hand will not collide, and you will do it comfortably.
Yeah.
Just see, we are just raising the annulus superiorly. Super raising is not a big deal. When we will reach inferior and we will elevate inferiorly without any bone overhang removal, then this could be the great deal.
Yeah, agree with you.
And we will be able to do that.
Yeah.
You just wait for a while, and ultimately I am just going to show you a little faster. Yeah. Yes. See that?
Yes.
Able to see
Yeah, I'm able to see.
without any canaloplasty.
Yes, we can see that. Yeah.
And when we lifted this much of the annulus in this much of bony overhang, and we are able to see, then any canal could be the canal of endoscopic tympanoplasty without a canaloplasty and with the control of all hidden corners. We can use 30-degree. You can use a slightly curved instrument for that also if we have a larger bony overhang. Okay.
Okay.
So we are just seeing the every hypotympanum. So this is way how the difficult situation can be tackled.
Yeah.
And this video, another video, just is combined approach tympanoplasty in cholesteatoma, where removal of also. So how the cholesteatoma is looking from back. You open the cavity.
Yeah.
Okay. So this is a cholesteatoma looking from back, and when
through the mastoid,
through the mastoid in combined approach.
Yeah.
And for me, when I do combined approach, what I do, this is a combined approach. When I just make it oh sorry. The message is here from my side is that when you need a sustainable construction, cartilage is not reliable things. When it's soft tissue reconstruction, soft wall reconstruction is, I think, it's not a good idea. Because you are not making a year for 1 or 2 years. You are making a years of a lifelong.
Yes.
You are targeting, you must target lifelong. Cartilage in a vertical position will never give you any reconstruction for permanent, and you can't think of that one even because you are just must be acknowledged. You must read and learn that middle ear is a very dynamic structure.
Yes.
Always ready to pressure changes, always ready to have some sneezing. Everything is happening in middle ear. Yes. It's not a static, it is a dynamic. And cartilage in vertical position, do you believe that? So if you are giving cartilage, you must have a bone support just beneath that. And that is why if you remove only medial portion of the your posterior canal wall, choose your program. Okay. My Microsoft is having some problem. Hello, are you getting me?
Yeah, very much. You exited the slideshow.
The
slideshow. Yeah.
The video is coming. Just you need to have some portion of the bony canal, that is the lateral, at least lateral portion of the bony canal, to make the wall medially based upon the bone.
Yes.
Other always you will have some collapse of your middle ear reconstructed ear. And can I escape it here? I just restart the program.
Yeah, you can start
Can I
this
do?
thing. Yeah, you can go ahead.
Because my Microsoft PowerPoint is not working.
Okay.
Yeah,
Okay.
waiting for that is coming.
Mhm.
Some technical issues coming.
Yeah, we even
So
had
after making the soft ball, yeah, yes sir.
no, even I had some technical issue here with the net here. Go ahead now. I can see, but we don't
Yeah.
have your presentation yet.
Yeah. I'm just coming. My either I stop sharing now or pin again sharing. Yeah.
Yeah. You can
So
restart
I can.
sharing. Yeah.
Yes. Wide pixel. Again, the same thing is coming. So I think I stop sharing again, and I will close that. Yeah, I will close that. Yes. Now I will open.
Yeah.
Again.
Open it again.
Yeah, files. Okay. Just wait. I minimize. No. Okay, can minimize. So where to go? Yeah, yes, right. Coming.
Okay.
Are you getting me?
Yeah, we can see your computer screen. You have to open that and sharing.
Yeah, just completed. Okay, that is happened. And this is again the close. And we are just here to the wide fixity.
The PowerPoint is opening for you.
Opening. Yes, I share.
Yeah, now you should share the PowerPoint presentation again. I think you should stop sharing the desktop.
Stop saying this. I'm this.
Desktop. Yeah, and share this thing again. Now share again. Now share this time PowerPoint presentation.
It's okay.
Yeah, it's opening now. Yeah, perfect. Yeah. Yes.
Yeah, wide fixity.
Yeah.
So this is a combined approach, and in this approach, what I did is just see making only posterior wall of the posterior canal
External
wall,
canal.
and we are
Yeah.
able to make a canal. Only removal of posterior medial portion of the posterior canal wall will serve you almost all purpose in terms of removal of disease in toto.
Yes.
And you can inspect by two ways. One is transcaval, and another is a posterior. What you have made the cavity. Did the cortical mastectomy there?
Yeah.
Again, this problem is happening.
Yeah,
so in
it's
this
okay.
way,
It's okay. We can have a separate event endoscopic cholesteatoma surgery at a different settings. Okay, we'll restrict ourselves to the endoscopic maringoplasty or tympanoplasty today. Okay. Yeah.
Again, there is a
there is some issue with this
close
thing. Yeah. It's okay, no problem. Anyway, You wonderfully demonstrated the endoscopic tympanoplasty part. You have anything more to say, Dr. Sanjeev? You have given a fantastic idea about entire idea about endoscopic tympanoplasty. So you have anything?
Nothing extra, but one, 2 or 3 points also.
Yeah, please.
Is there any fight between microscope and endoscope? Do you think that? Hello?
See, there will be
Hello, sir.
There will be a difference of opinion. Okay. Can you hear me?
Yeah, I'm getting you.
Yeah. See, there will be difference of opinion. So whenever some new technology or new technique is developed, there'll always be for and against the thing. See, I am of the opinion that any new technology, new technique, we should accept it. Okay. Yeah, maybe so somebody wants to follow whatever they're doing, and somebody wants to do some new thing. They want to embrace the new technology. All that is how the science grows. Science doesn't grow if we don't show the dissidence. In a democracy, dissidence is very important. So
Very important.
this is very important. We should always have a difference of opinion. That is how the science grows. Yeah, I agree with you. So that's why I was very open, very much open for this topic to be on our platform, and you have wonderfully demonstrated the entire the nuances of endoscopic tympanoplasty. I think with this, we should invite questions.
Yeah.
Friends, any questions now?
Dr.
It's all
Prakash,
open for you.
hand. Dr.
Yeah.
Prakash, sir, please.
Yeah. Any questions, friends?
Munka sir has raised the hand.
Yeah. Okay. I will unmute you, Dr. Prakash Munka sir. You can. Prakash Munka sir, I have unmuted you. Dr. Ramesh Rohiwal also has. I'm unable to unmute Dr. Prakash Munka sir. I will unmute Dr. Ramesh Rohiwal sir. Yes, sir. Dr. Ramesh sir. Unmute
Very
yourself.
good evening.
Very good evening.
Very good
I
evening,
unmuted
sir.
myself. Am I audible?
Yes, very much. Loud and clear.
Super presentation.
Yes.
Super presentation.
Yeah.
My only concern is about the denuding the malleus, because during that procedure, it tried to denude completely because no epithelium or cartilaginous layer, as he has correctly said, the shell of the malleus and all. There is a lot of handling of the ossicular chain. And you should do minimum handling when you are doing the things. So is there any observation that we can cause some damage or some sensory neural loss because of more handling of the ossicular chain? Is my concern, not a question.
Yeah. There's a paper when you are transferring energy to the inner ear while handling the instrument, chances of getting sensory or hearing loss will be there. How to fix it even in microscopic? One hand that will suction or other instrument to make the handle of malleus stable. But when you are having one hand only to work, you can push you can have a cottonoid ball anterior to the handle of malleus, 1 or 2, just pointing to going posterior, and start from superior. Actually, neck of malleus, you expose the handle lateral process of the malleus, and then take incision over the perichondrium of the entire length up to umbo, and then start denuding from superior, and ultimately when you reach there in near about umbo, you just swap it in circular manner. Then you will be able to clear your umbo without any fibrous tissue, because there is a firm attachment there in umbo, ear umbo. Are you getting me, sir?
Yeah, perfect.
So this is way how you avoid excessive manipulation of handle of malleus, and chances, and how you avoid the sensory hearing loss.
Yeah.
By this way.
I think at the
brother.
Yeah, Dr. Prakash Munka sir. Yes, welcome, sir.
Yeah. Basically, this question you raised about microscopy versus endoscopy.
Mhm.
This over last couple of years, we are facing almost at all the meetings. As early as last Sunday, I was in Delhi. Delhi AOI had organized a program,
Mhm.
and I was in a panel, and this question was raised. To simple answer is, any transition is painful because it needs adjustment. We are basically trained into microscope, then came into this. I give a simile. I was in general surgery. I used to do open cholecystectomy when endoscopy conversant with the technology and didn't want to change my method because I was very comfortable.
Your voice is not coming, sir.
Sir, you have muted yourself. Hello.
Out
Sir,
of
Prakash Munkar, sir, you have muted yourself.
no, might be some yeah.
Yeah, okay.
Yeah. Yes. You unmute yourself, sir.
Unmute yourself.
Yeah.
Okay.
Hmm.
Now you are getting it?
Yeah,
Yeah,
yeah.
we have.
Yeah. So once I did that with a great hesitation, once I pushed the gas after putting the laparoscope, I found the job of the third assistant, which was unimaginable. That how can you do a cholecystectomy without a third assistant to pull the lever? The gas does that work. But at the same time, there was a caution. One should be prepared to convert because there our basic training was much longer in open laparotomy than the laparoscopy. Here, the difference is our inner approach is more or less same. Even if you do with a microscope, we are doing the same work, whatever we are doing with the endoscope. It is just a question of your orientation. And the persons like we who have been trained in microscope, we have to do certain degree of unlearning and then relearning with the microscope. But young chaps, Sanjeev, you will agree with me, when the young students come, they are more comfortable with the endoscope than this. I have started endoscopy since last 3 years fully. I am very much satisfied because now I am in private practice. I can't carry the microscope to nursing home, and endoscope I find handy. And in most of the cases, my job is very easy. If and I am very open to discussion. Sometime I phone Sanjeev, Ahila, how you are putting local, how you are putting Tarabiti stitch. One should not hesitate, and all people are so nicely to the junior. And I think none of the seniors will mind if I call you and say, sir, I'm doing this. I want what should be the step. I am getting that. Everybody feels very happy. So that is the thing is we should not be reluctant to accept the technology. And Sanjeev, excellent this topic since last 1 year. I wanted you to bring to this forum.
Thank you, sir. Thank you very much.
Yeah. Any more questions,
Yeah,
friends?
Dr. Prahlad.
Any more questions, friends? Yeah. Anyway, Dr. Sanjeev, you explained so well. You did such a great job. Really, hardly any questions I see from our friends. So thank you very much for spending this evening with us. With after all that technical issues 2 weeks back, and again today also we had several technical issues. Nevertheless, we were able to do the program, a wonderful program. Really, you gave a very great insight. Backed by proper science. That's what I appreciate. Backed
Thank
by proper science. Wonderful job. Keep it up. You're doing great job, and train more people in this technology and in this technique. Start fellowship programs at your hospital. Specifically in endoscopic surgery. I think that will do a great service. Our specialty and our country concerned. And I want to see you even at higher places. I know you organized a global endoscopic ear surgery event, but I want to see you at the international places. In a higher places. Definitely, we'll also have a endoscopic cholesteatoma surgery sometime in future on this platform. And thank you very much for sending with us and teaching us this technique. Thank you very much, Dr. Sanjeev. Yeah. Thank you all joining us from different parts of the world. Really, you made this event possible. It's because of you. You are our motivation to do this program continuously. Please be with us. Join us again day of tomorrow at the same time. Okay, we are going to have an event with cochlear implantation, facial research technique. Yeah. Thank you all.
Okay. Thank you. Can I leave the program now?
Thank you. Yeah.